Okay, the doors are closed. That means it's time to get back to proceedings. I hope you had a good lunch. We are now going to head into the afternoon part of the program, and we are starting with two interwoven, rather important topics: the digital transformation and technology, and healthcare. And we're going to be discussing the implications of technology, and especially artificial intelligence, on healthcare and what it all means. Before we get started, we are going to have some opening remarks by Frank Hester, OBE, the founder of TPP, one of the partners for the Commonwealth Trade and Investment Summit. Frank is going to give us some perspectives on the issue. We will then head into a panel discussion up here on stage. So without further ado, Frank Hester, stage is yours.
Well, thank you. Well, it's nice to be back and see some familiar faces. My name is Frank Hester, and thank you for the introduction. I'm a computer programmer by trade, and we produce healthcare software. And we work around the world from South America all the way over to China. And in some of the countries here represented from the Commonwealth. We do national scale EMRs, electronic medical records. We're very much about one citizen or one patient and one record. Not lots of different records spread around. Bring the records together, make sure that your primary care, perhaps your GP record or your nursing or your midwifery record is in the same place as your ED record. And I thought it would be topical to talk about AI today. There's been lots of talk over the past few weeks about artificial intelligence. It's been a big deal in this country because Prime Minister Sunak was hosting an event and quite a lot of people came to it. So I'll touch on that. I think we have some key themes, some key shared problems or challenges around the Commonwealth. No country I go to says, Frank, don't worry, we've got enough doctors in this country, or we've got too many nurses. You know, we all suffer from those challenges together. And I don't see that challenge getting any better, unfortunately, in that we can't magically produce more doctors, and healthcare demands are unfortunately increasing as we're able to do more and more to help each other. Everybody needs to expand capacity to care for their citizens and to improve access to healthcare. I don't think anybody's got a perfect healthcare system, with some very good ones, but they can all improve. I certainly had an interesting experience in Bangladesh this summer. I had no appreciation of the challenge of the out-of-pocket expense that citizens were having to pay just to access healthcare and having to travel, and that was a big challenge for the people of Bangladesh. Here in the UK, it's extraordinarily political, our backlog to get outpatient appointments in hospitals. We have some people, unfortunately, waiting years. And it's a massive challenge for us. And I think to varying extents all over the Commonwealth, we share a glimpse of these problems together. And it is my firm belief that artificial intelligence gives us a joint opportunity to deal with some of this. I first studied AI at university a long time ago, an embarrassingly long time ago, about 30 years ago. Unfortunately, I mean, the theory was there. We sort of knew how to do it, but the computers weren't powerful enough. They just sort of, you kind of get it going and then it just flop and break or whatever. You get the blue screen of death. And so I kind of gave up on AI, and I thought it's 100 years away. You know, it's never going to happen in my lifetime. I was very confident of that, and I was wrong. Not the first time. But developments in mathematics, and very oddly, something called a graphical processing unit, a GPU. And this is the thing that we use to make for video screens, to make the wars or the driving the cars or whatever, the computer games that teenage boys play in their bedrooms. You need exactly the same matrix manipulation in mathematics as AI needs. So we finally found a use for teenage boys, and I'd like to claim some credit for that, for playing my own part in playing games in my bedroom. And this has brought AI forward, shockingly, about 50 years before I expected and many people expected it to happen. And a few years ago, it all just kind of came in a bit of a rush. And there's a fantastic feature on, where do they have all the movies? YouTube, Netflix. No, YouTube. And you can watch AlphaGo, and it's the start of Google DeepMind. And it's fascinating, and you can see the moment where we really get true AI. Rather than just some of the computer programs that we'd had before were just try this, and it wasn't AI as we'd call it. Well, I was intrigued by this, and I thought I would like to produce some AI, but I was a bit busy. And then by a sort of an accident of happenstance, I got stuck in Dubai, and I didn't have my passport, and I couldn't really get out. So my company sent some people out to Dubai to work with me. And so we had some spare days. And actually one of my colleagues, Chris, who was coming on later on, so we sat there for some days and thought, how can we have AI? How do we do it? What is it that we would want AI to do for us? Google had already was doing driverless cars, and I think Apple are doing that as well. And there were already AIs that were reading MRI scans. We had millions of patient data, and lots of doctors' notes. And the question was, what game can we play that's going to be beneficial to patients and beneficial to doctors? And that took some days, didn't it, Chris, of trying to work out what it was. And we call it a game, but it's actually a very, very serious thing. But it's just a way of trying to frame the challenge. So we decided to try and beat the clinician, the doctor or the nurse at the game of consultation. Could we reliably predict what the doctor was going to do in a consultation? Could we bring that forward? And so the patient got a result quicker. And I think there was a sense of disbelief from the doctors that we worked with that this could even happen. But they challenged us by saying, model ovarian cancer. In the UK, this is sometimes called the silent killer. It's often by the time a lady unfortunately realises she has ovarian cancer, it can be too late if we've got to stage 3 or stage 4. It's an extremely difficult one to spot. And the average GP in England, in say a 40-year career, might only see maybe 6 ladies with this dreadful disease. And if you think about you doing 10-minute longer consultations, to spot over 40 years 6 to 7 ladies with ovarian cancer is a mighty challenge. And it's no surprise to me that sometimes it's missed with the best will in the world. We developed a model, and what we discovered was that it was always as good as the GP. So we can now detect ovarian cancer as good as the GP, but more than 50% of the time, we can beat the GP. Moving that prediction for the lady back from stage 4 or 3 back to 2 or 1. There was silence in our office when this happened because it was like looking into the promised land. We knew something amazing had happened for us. And that we were able to do this from essentially, which I'll come to later, reading the doctor's notes and putting the symptoms together was for us like landing on the moon. You know, it's as close as I'm ever going to get to landing on the moon. And so we then went on to model more and more, so we could detect more and more cancers. And then we went on to model what a GP does. And we can now do over 50% of all the consultations that a GP in the UK would do, which means that on a smartphone, Simon got one. Anyway, you've all seen a smartphone. Imagine that I'm holding one. We can put that access to anybody in the Commonwealth, and it can just be given to the wise woman in the village, in the remotest village, and they have access to 70 years of NHS knowledge from hundreds and hundreds and hundreds of doctors, the power of that in their pocket, and we can make that available. And of course we want to do more. I believe this is the future. This is our step forward, and a step we can make together, and we can pool knowledge to do it. Because, as I said, nobody's saying to me, we've got too many doctors. Nobody's saying we've got too many nurses, and we've got a backlog. And you know, I'm not talking about spending a lot of money to do this. You just develop the models, download it from the App Store, and it's on your smartphone. And this is the power of big data, an EMR that transforms your country and sits right across your country. Once you've got one of those, you can build the AI. And we did a lot of that during COVID. We partnered with Oxford University. And I would say a key thing for any country contemplating this, I think it's very, very healthy to get the private sector in where the private sector, but it's got to work with government and also with the academic side. So we had a marvellous partnership between government and Oxford University, and we're still doing it. And we've still got a national research platform which is used by dozens of universities and looked at by, many tens or indeed hundreds of countries around the world. One of the major challenges is, and it's been really interesting recently, is doctor's notes. Doctor's notes are notoriously hard to read. I hope I'm not insulting any of the doctors in the room. I don't really care. I'm just jealous of you all. But they're hard to read. You know, this is an advanced thing to be a doctor, and to understand what they're saying is no easy task. But we did manage to do it, and we started. The most interesting one we started with it was the lack of taste and smell, because our doctors tended not to have codified that information before COVID, because why would you want to put in the code for that? And suddenly during COVID that became very, very important, and it became very important for us to try and dig into those notes and find, because these were the people who likely had it, and then you could use that to spot the outbreaks. So we labelled it, we call it labelling a data set. You've all actually probably done this. If you're using Google and it comes up with the thing of show that you're not a robot, and you have to click this thing and say, I am not a robot. And then it asks you to tick all the squares with zebra crossings in, or traffic lights or motorbikes. Well, what you're doing there is you're training an AI to drive a car. You're training an AI because you're labeling the data set. You're saying, that's a zebra crossing. We get enough people saying that, it can then discern what a zebra crossing is or what a motorbike is. We use exactly the same technique on a doctor's consultation. We sort of, we look at this thing and we label it and says, that is somebody who's got fever, that isn't somebody who's got fever, that is somebody who's lost their taste, that isn't somebody who's lost their taste. And you do that enough and the AI can start learning for itself. And now it's very exciting with the possibility of large language models, the work that Sam Altman has been doing with ChatGPT. And I must say I was delighted. If any of you have been watching those events, Sam Altman got an award, the Hawking Award, which we've been sponsoring for years. I was delighted that he won it. I think it's an outstanding piece of work he's done, and the power of AI. Some of you may have read, he was sacked by the board of his company, and within a relatively short space of time, the board of the company was sacked and Sam was back. I mean, that tells you don't mess with anybody who's doing AI. It's so important now. We do need to be careful that we maintain the trust of the doctors. It's very, very important. And I was chatting with Rishi Sunak about this, our Prime Minister, just a couple of days ago. And I liked his idea of, he said, we want doctors to think of this as a co-pilot. You're still flying the plane, but there's just something there to help you. Previously, I've compared it to a spelling checker. Very good and very useful, but I'm not worried that I'm going to be replaced by the spelling checker. I'm not worried that the spelling checker's going to, take over the world from me. It's just a blooming spelling checker. That said, I also had the pleasure of meeting Mr. Elon Musk at the AI Summit a few weeks ago. And I think he's often misquoted, but he was saying a few things that I thought I'd share with you, which I found personally to be very powerful. One, he was saying his personal belief is that the risk from AI is absolutely minimal. But the problem is, if it goes wrong, it could go very wrong. And I must say I agree with him. We should take the time to make sure it's safe. But he was also saying AI is coming much quicker than you think. And I'll tell you sort of a personal anecdote. He was saying that AI has the possibility to be your best friend, your personal tutor. And he explained that his son had autism and that AI had the potential to help guide his son through a world which his son finds confusing. And that kind of made sense to me, and I spent a lot of time thinking about that. And when I came home, I was chatting to a lady who was working on my garden about it, because she's got autism. And she has a 12-year-old daughter who also is autistic. And she was saying that she's been using ChatGPT for some months now to create bedtime stories for her child, and that the bedtime stories have all her child's friends in the stories, and that they're continually growing. And I thought, wow, that is something. When Elon said it a few days previously, I was thinking that's sci-fi, that's the future, having AI as a friend. And I'm chatting to somebody in my own house and they're saying, I'm doing this with my daughter. So it is coming, and they'll be coming in unexpected ways, and we should watch. But I think if we work together and share our experiences, good and bad, I think we'll get some good results. So we don't have to start from scratch. And certainly my company's happy to share the knowledge, and I think the more we share, the more we can do together. So I look forward to this exciting time. Thank you very much.
Thank you very much, Frank, for setting the scene so brilliantly for this discussion, which we are now going to pick up on in the form of a brief panel discussion up here. I would like to invite up to the stage to join me Professor Birgitte Andersen. She's the CEO of Big Innovation Center. Yes, go for it. Dr. Chris Bates, the Director of Research and Analytics at TPP. And Asif Chaudry, who's Consultant Robotic Cancer Surgeon at the Royal Marsden Trust. Okay, in some ways, Frank has made this discussion a little easier for us because he's set the scene quite well and touched on some of the core issues that are part and parcel of any discussion around digital technology, especially artificial intelligence in healthcare. He's spoken about how the breakthroughs are coming much sooner than had been anticipated, and that people like Elon Musk are out there saying it's going to hit you a lot sooner than you think, and it might come from unexpected sources. So we have one, the kind of the enormity of the change that's coming our way, because correct me if I'm wrong, but I suspect in AI terms this is still early days, and if it's just as disruptive as this now, we can anticipate there'll be a hell of a lot more. Frank also gave examples, concrete examples of how AI is in a very real way changing how people access healthcare, how people are able to benefit from healthcare. And I would say we pick up on those two strands really. One is the realities and the practical application of artificial intelligence, how it is changing the nature of healthcare. And it would be great to get perspectives from all of you in that regard, but then also some thoughts and discussion about the bigger picture here. Like what does it mean in a very fundamental way? What kind of trends do we need to understand? What kind of technological breakthroughs might be coming our way that are going to really redefine things? Now, we have just under 30 minutes, so I say we try and make this as free-flowing a conversation as possible. We had a pre-panel warm-up, and these three basically just went away and started chatting amongst themselves. I'm hoping that you will continue to do that now, but just as sort of maybe just yardsticks for the overall conversation, there are four themes that have been that we've been asked to kind of pick out. One is how artificial intelligence can relieve pressure on public health systems, and that's something that Frank also touched on. I'm sure something that all of you will have perspectives on. The issue of trust in artificial intelligence, obviously also an important one. This here particularly relevant to the Commonwealth and emerging regions, AI and the digital divide. So we know that not all access to the web is equal. A lot of people who don't have access, and even if they do, they have poor access to the web. And in the 21st century, that has all sorts of implications for one's ability to be a productive member of the economy. And we have AI and health tech regulation, another essential question. Now, let's have those in the back of our mind as we discuss this, and maybe start with the first one, which is, how does the digital transformation, how does artificial intelligence, in a very real way, take the pressure off healthcare systems? Frank made the point that we have an acute shortage of healthcare workers, not just in this country. It's much worse when you go to a lot of emerging economies, where it's calling it a shortage is quite an understatement. So I'm just going to throw that out at you and give us two things. Give us your practical experience, what you're seeing, the application of artificial intelligence, and your thoughts on this bigger picture of what's the relationship between healthcare systems and artificial intelligence. Who wants to start? All right, all of them. You see, I told you. They can't wait. You have the misfortune of sitting next to me, so you go for it, and then we will just see how the conversation.
Where do we start? The world is unhealthy, sadly. We're in a world in which, if you look at surgery in particular, which I'm a cancer surgeon, I work in surgery, so I can speak about that from a sort of intimate perspective. Globally, 5 billion people of the 8 billion population of the world don't have access to safe surgery at the moment. And a significant proportion of those people are amongst those 2.5 billion people within the Commonwealth as well. Around 17 million lives are lost every year through a lack of access to that surgery. But when we talk about surgery and when we talk about needs and the needs of the specific individual, where do we start? We start about that sort of latent disease process that exists within the patient, undetected, at home, with symptoms or without symptoms. And that person then engages with a human, a person, a community worker, a doctor, a nurse, whoever within the chain, who then has to reason, use their judgment to triage and consider what the next step might be for that person to move into a healthcare system. And the extent to which that's provided at the ground level varies all the way across the Commonwealth, all the way across this country. And the real benefit is trying to, in applying AI, I think, and digital tools, is to gather data from latent problems amongst the broader populace and bypass that decision making at the level of an individual. And as you funnel to a higher and higher level, up to a specialist level, then providing that sort of co-pilot tool and the associative help that's evidence-based, that can assist individual specialists to move on and provide the best possible care. And that's not necessarily just at a narrative communication sort of level, but also at the level of machine vision, interoperative tools when we're carrying out surgery, the ability to detect and understand differences between the texture and the nature of tissue, not only at the level of what we can visually see, but also discern at a molecular level using other cues. All of that is really coming together in a big way globally at the moment. And I just see this becoming better and better and better as our tools get better. And I can expand on any of that, but there's a lot to talk about.
Yeah. Well, I can build upon that and say that I run a think tank, the Big Innovation Centre, and we do evidence for UK Parliament in relationship to AI's implementation into different sectors. And one of the we mentioned healthcare a couple of times, but we actually have looked a lot about health prevention. So AI can help to prevent any diseases, and it can just do some very simple things like fitness apps or things like you can use to control your epilepsy or other kind of health diseases, diabetics. So there's the prevention. And then, of course, and we had the COVID app also to prevent we get the infected. And then, of course, we have the cure and how AI can help in precision, as you mentioned. It can help in operations. It can help in cure in many other ways. If it's mental health, it can be very useful in cure. And then, of course, we have care afterwards. And there AI can help to control your pacemakers when you take your pills. It can help to control your life if you live with Alzheimer's and other things. So it can be very important there. So there's both the physical health, the mental health, and the fusion, which is more related to body hacking, but now also AI is being developed to control your nervous system and control your sensors. In that sort of you lost some of your senses like seeing and hearing, then AI can come in and help that. And then, of course, in terms of the burden, of course, there's a huge burden we can relieve here. And then on the top of that, we have mobile hospitals, where actually that means hospital through your mobile phone. And we can talk about that maybe later. But this is really, there's a whole area of ways in which we can cure these diseases or prevent the diseases or live with them through our mobile phones. And that was also mentioned by the founder.
Great. Yeah, I'll build on it as well. And I think our position is, I'm Director of Research at TPP. I work very closely with Frank. And our position really is that there's been too much hype in the AI world now, and the time now is for delivery. And delivery on really practical things for doctors and nurses and for patients. So the approach we've taken is to focus on those real problems and to say how can we solve them with AI and machine learning. And just give you some examples. Frank, of course, has mentioned the cancer example, which is incredibly powerful because it's just using the data that we can collect directly from patients and we can target those questions. It's not an expensive intervention, but what it's doing is it's allowing us to really get prognosis much earlier for people in primary care with undiagnosed tumour sites. So improving outcomes, really, for a thing that we have poor prognosis and poor survival rates for some of these cancers, and it's making a tangible difference. Just building on the prevention bit, we've done some work as well. Of course, diabetes across every Commonwealth country is a major and growing problem.
but we're still in a situation where we have standard targets for everybody across, all of our patients living with diabetes get the same targets. But we can use big data and we can use AI to change that. And we've done some work on diabetes and on looking at different clusters of patients. So what that means is we take, the diabetic population and we can see that people have different characteristics, which mean they need different targets to help improve their outcomes and stop people developing complications. So of course that's great for patients because they're not going to go on the wrong trajectory and pick up more and more difficult conditions. But it's great for the health service as well, because as people get more and more long-term conditions, it becomes very costly for the health service and it puts more burden on staff. And finally, just as a separate example, away from the clinical side, is how do we use AI to help our service reduce burden and help our services run more efficiently? And one of those problems are people not turning up to appointments that they've booked. So doctors and nurses are waiting for the patient to come and they just don't. As an example, in GP, in primary care in the UK, there's about 7% of appointments are not attended. So it's up to 20 million appointments a year with GPs and practice nurses. It costs the health service upwards of £200 million every year. So it's a massive practical problem. We speak to a consultant nephrologist we work with, and he says for his clinics, he overbooks. If he's got 12 people coming, he books for 15 because he knows that they won't all turn up. But sometimes that means everybody gets a bad experience because they're waiting, and sometimes it means only 8 turn up and he's twiddling his thumbs. But we developed an algorithm to try and solve this problem, to solve this problem, which is using demographic factors about patients, socioeconomic factors, their clinical conditions, things like how far they live away from the medical centre, when did they book the appointment, and we can really accurately predict who's not going to turn up for that appointment. So taking the guesswork away from our doctors and giving them the actual accurate results. That's now live, it's in our system, it's being used by GP practices in the country. And an example practice in the last few weeks has told us that their DNA rate has dropped by 30%. So they've freed up hundreds of appointments that would have been wasted, appointments that people want. So I think from our point of view, it's those really practical issues that are facing health services that AI can tackle now, rather than it being into the future.
Can I just comment on it quickly? I think there's 2 issues that are very important. The one thing is the private investment going into it. And I think that the National Health Service in any country, developed or less developed, always have a problem with the burden of the National Health Service. Of course, is a huge cost, and there's a lot of debates on how much money to spend. But with all that private investment going into artificial intelligence and into AI-driven health, I think there's actually a huge opportunity for the National Health Service not to do less, but to do different things, where they don't need to do the routine tasks which are being done to the AI on the mobile or the AI in your house. That's one thing. The other thing is the issue of not turning up to appointments. The whole issue, the idea with AI and adoption of AI into your mobile phone or into other parts of your home is, of course, that you don't need to turn up to the doctor, because you're supposed to have healthcare on the go and helping you in the preventions, in the care, in the cure, etc. So when you have healthcare on the go, you don't need to turn up, but there will be full information at the surgery on the diagnostics. And if you have a problem, then they can bring you.
So can I just come in just on that point? So in terms of not needing to turn up, I think a lot of primary care consultations and interactions can be automated. I think the level of the checklist at that sort of primary care level it can in many ways be supported by generative AI in the next generation now. And when you also spoke about patient parameters and data recording in terms of physiology, we're also moving towards wearables that will give us increasingly more sort of chemical notes as well, with molecular integrated probes being integrated into wearables for interstitial fluid detection and other things that are on the horizon. So I think there's going to be much more of automation of that initial primary care level. At a secondary care level, when I'm sitting looking at a cancer patient who might be seeing me for a second or a third level opinion from anywhere internationally, my task is different. There's often a very complex patient journey that the patient's been through, with scraps of information in all sorts of different formats that haven't been put together in a digitally recognizable form. And the quality of the information coming together from a CT scan in one place, a PET CT scan somewhere else, with an individual's judgment, again, isn't appropriately aligned to be able to be sifted through in a large model accurately to then give you the best predictions. And Frank earlier spoke a little bit about taking UK data, which is great and very robust, but there will always be some issues with applicability when it comes to bias in other communities that we also have to be sort of mindful of too. So I think there are great potentials in all of this, but you know, it's just moving so rapidly.
I mean, it's interesting. We will talk as a agree, and as Frank said, we've been able to model 50% of primary care consultations in exactly that automated way, and we only stopped at 50% because the pandemic hit.
Yeah.
And we pivoted all our AI work onto helping with the pandemic, so we know we can do more than that. And of course, that is information that is, you know, 7 years of GP training in the UK. It's really, really high quality data and high quality information. And the ability to be able to put that into someone's hands, to be able to guide them through the consultations in areas where you wouldn't have it, I think is an exceptionally powerful opportunity. I think it does need to be combined with new technologies to keep for things like hospital at home and remote monitoring. So work we've done enables you to, through Apple Health Kit and Google Fit, so if you've got an iOS phone or an Android phone, for example, that any data you collect from Bluetooth devices or any surveys you fill in on your phone, for example, link directly into your electronic health record. So if I give you an example of how that, the use cases that we see from primary care that they want to start bringing that technology in, it's things like patients living with heart failure. Mm-hmm. And if their weight increases, they need to have their medication changed. And that would normally, you know, in the old model would take an appointment and it would be a booking and you'd be waiting. But now, through Bluetooth scales or just inputting your weight, it can go automatically to the doctor who can say, you need to, you know, this change to medication. So we can change these into new digital pathways with technology that exists now. We're not talking about anything that's, you know, sort of sci-fi or off into the future. This is happening now. On our database, we have over 30 million readings that people have recorded themselves through Apple Health Kit and Google Fit. So it is a reality. And I think it's a reality to bring to lots of different countries. It's not something that will only work in the US or only work in the UK or Germany. There's the ability for us to get this across the Commonwealth. It's very low impact tech with a really high impact result.
But before I let you continue, and I don't want to interrupt the discussion, but I also want to bring in here, and maybe this is something you can weave into your comments, the issue of trust in an explicit way. Chris, you kind of touched on that, talking about how AI has been kind of overhyped. And there's certainly a lot of confusion out there and some skepticism. I will put my hand up and say I'm one of those slightly confused and skeptical people, because a lot of the talk about AI makes it sound almost magical, like there's nothing it can't do. And it would be good to get some thoughts on how do you effectively communicate what is this artificial intelligence that we're talking about? To what extent does that help build trust? What are some of the issues around that? Sorry, Birgitte, finish your comments and then maybe we can move on to that.
No, I think I can comment on the thing of trust because I think that one of the big areas here is people trust it better, of course, if they know what the AI can do for them. So the use cases are phenomenally important. The other thing that's very important is where I think where government come in and help actually to kite mark all these mobile apps and help. They are hundreds of thousands of mobile apps you can download on health, on mental health, on femtech, on anything. And it's very important that we kite mark which apps have seen a doctor and which have not, because many of these apps that claim to do mental health they have never seen a doctor. They've only seen a software engineer. And these are issues that we dumb it down, what's really important in health services. So I think that trust is built by having a kite mark for the National Health Service on what good looks like. And then, of course, also the whole area of data governance is very important, that we know what happens to our data. Then I'm one of these people who might be a little bit controversial, because I think that we have this thing we call GDPR, where we can control our own data, and of course that's very good. The problem is that we don't know how to control my data. I don't know how to control my data. I accept every single cookie coming through my computer, because I don't. As soon as I said don't accept, then I cannot do what I want to do. Or if I try to sort it, I don't know how to sort them, so just accept. And then I delete all my cookies every week. But I think that this is another way in which we manage our data. So I think these are, and then I think also we need also to think there are many parts of the world that don't have access to healthcare, and either you have no doctor or you have your mobile phone in which you can get very high level of services, hopefully in the future. And then I think that the trust has to be, again, the government has to move in and regulate very heavily on what good looks like.
I just want to add something. So the trust is a very kind of complex, multifaceted term. So part of it is some of the sort of legal elements of consent, is one that you spoke about, and owning your data. Another element in terms of AI, particularly in sort of machine vision for digital pathology and radiology, is accuracy. And for certain cancers like breast cancers, lung cancers, myeloma as well now, there are lots of visual models that actually give results that are better than a radiologist alone, or can enhance what a radiologist sees or what a pathologist sees when they're in combination. So that's a co-pilot sort of element again. So when we're flying, we don't usually ask if we trust the engine of the plane or the co-pilot in the plane. There's an automated system that we've come to trust over time because it's become the industry norm. And it might be the case that in the future with health and medicine and surgery might go in that direction too. Now, specifically in surgery, it's been about 7 years now since the first automated surgical robotic tests were carried out with suturing real tissue inside the body at Johns Hopkins, and where the machine actually decided where to take the bite of tissue to do something. And at the moment, we're still within a sort of master-slave relationship within robotic surgery, but that sort of process of trusting a device is coming. They just have to get better and better. There are some biopsy tools that can be trusted too. But at the moment, it's better to have that combination. Another element in trust, though, specifically in healthcare, is care. Okay, so people do actually like to have the care of another individual who can empathize, and we can replicate that to some degree, as with the example you gave with the autistic child and so on as well. But there is a particular warmth that comes from an empathetic individual, and I'm not sure whether or not we'll ever be able to replace that entirely. So I think these are great, wonderful tools that are going to energize our world, but won't necessarily replace humans entirely ever.
Yeah, I just want to pick up on data governance, because I think we've been using algorithms in healthcare for a long time for cardiovascular disease scores, etc. And AI has moved that to another place with more sophistication. But underneath the hood of all that work is data and big data, and I think some of the trust issues come around people not knowing how their data is going to be accessed for research purposes, for AI development purposes. But I think we've got big opportunities to solve that. And Frank mentioned earlier the work we were doing with the University of Oxford and London School of Hygiene and Tropical Medicine during the pandemic on behalf of the UK government. And when the pandemic started, the question that came down was, will you work together to build a massive COVID research platform covering tens of millions of patients with all their primary care data, hospital data, eventually vaccination data, COVID testing data. So of course, that's an enormous resource, and people get understandably worried about having all that data in one place and how it's being used. What we were able to do with the Oxford team was to build a new model, really. So instead of traditionally, you might give extracts of data out to people, and then are they on a USB stick? People are worrying about where those things are, quite rightly. And the model was different. We brought the analytics to the data. So where your electronic health record is already really securely stored in a data center with all the protection around that, the ability to create algorithms and to run research and analytics came to that. So you had that security level for free, effectively. No one gets to see any of that data. It's all securely there. It's just computer code that executes against it, and then only the results go back. And what we found with that is that the medical confidentiality groups here in the UK have kind of looked at it, who are people who are really protective about it, have looked at that model and gone, it's pretty good. And then we've done things like citizen juries, so representative patients across the country organised by the NHS and the National Institute for Health Research, who are overwhelmingly supportive of the model of using the power of electronic healthcare record data to do analytics and research whilst maintaining that confidentiality. So I think we've gone through years of thinking we have to have one or the other. We can't have our cake and eat it. But that model shifted. The technology now exists to be able to unlock the power, but make sure people are happy and have public trust.
we have to shift gears, unfortunately, because we only got 10 minutes left. And I want to address this issue of the digital divide. So inherent to any kind of claims of digital transformation and the application of technology is the capacity and ability to access that technology. Web access being a key metric in determining who can and who cannot meaningfully participate in the digital economy. And when you go outside of places like Western Europe, you go to emerging markets, a lot of the things that here might be taken for granted aren't a given there. So data might not be very robust that's available, and essentials like, you know, simple things like transportation or access to power might not be a given for a lot of people. And even when it comes to connectivity, while we have, of course, through the mobile revolution, seen a real proliferation of access to communications technology, not everyone has great bandwidth, not everyone has cheap data, not everyone has fast devices, or the ability to meaningfully use this device. So when we now move this discussion over to, say, a region like Africa, sub-Saharan Africa, or the wider Commonwealth, what does the application of AI look like there? Or is it far-fetched to be talking about digital transformation, AI healthcare application, where people are concerned about, you know, how am I going to get electricity?
I would say that there's huge applications for AI in any region of the world, including the regions, which is kind of outside the satellites. And I think that because artificial intelligence works in different ways, and I'm really not an engineer, so now I speak about something I'm not the engineering on, but there is the thing where you need the satellite all the time, and then there's something called edge computing, and I'm sure there are lots of engineers here, where you actually are working with your own system until you're back on track to where you're linked into the whole world. And that means that we need to think that the biggest adopted wearable technology for healthcare is the mobile phone. And it's something that almost everybody have, including in slum, favela, shantytown, whatever they're called. They will have someone or know somebody who has it. So therefore, that will be a fantastic mean by which mobile health can be delivered, and that could be a mobile hospital. They can do eye testing. They can do everything on your mobile phone almost. And yes, if there's no electricity, yeah, well, unfortunately, of course, you need to have your batteries working locally in order to get your mobile charged, but to put in a good battery. If you can have a battery for a car, I'm sure you can put batteries in for mobile phones. So I think that this is really the future, is really the mobile phone. And if there is the problem with satellites can be solved through edge computing and other areas, but there has to be local infrastructure investment.
So well, what I would add to that is that old school solutions are not the answer. So bricks and mortar infrastructure being developed in countries as sort of holding bays and old school sort of pathway bottlenecks are not the solution when countries like Nigeria have a ratio of doctors to population of, you know, less than 1 per 1,000, both in urban and rural areas. So the solution has to come from the digital world, and with an increasingly younger population who are actually able to engage with mobile technology. And there are even off-grid solutions in terms of being able to recharge their phones and so on. That degree of penetration of the mobile device and the potential for mobile healthcare is ever there. And I think we have to think about how we make even physicians' assistants and less qualified healthcare workers more efficient in their delivery of healthcare. And you know, of course, we have to take the newest technology to try to energize that.
Yeah, I don't think there's anything that stops AI coming to a whole range of different countries with different infrastructure that's already in place and different infrastructure development plans. I would say to anybody in government here is pick your partners wisely. I'm just going to say it. You find big US vendors in our industry, in the electronic health record industry, who will turn up and say, you need to have this specification of computers, you need to have massive bandwidth in place, and then we'll happily kind of sell you those solutions, but they won't work. So I think what you need, and what we'll do all the time, is putting people on the ground immediately to say, what are the power problems, what are the power requirements? We need to have solutions that work offline in rural areas. We need to make sure we've got solutions that don't rely on massive broadband, that can work over 3G, for example. And it's got to be that the system that you put in place fits the infrastructure that you've got. That it can't be that you have to invest massively in an infrastructure program to enable healthcare. It's just too important for that. So it's the responsibility of the vendor and of industry to solve that for you. Once that's in place, exactly that. If you've got the phone and the AI, the algorithms are on the phone and it can work offline, there's absolutely nothing to stop that technology going everywhere. So the barrier is getting electronic health record systems in place with suitable infrastructure. Once that's in place, the AI comes for free. It will just work on top of it.
So just a tiny little note on that. So we've already seen in the fintech world how much leapfrogging has taken place in sub-Saharan Africa in terms of e-commerce and so on. Health is just the next industry to sort of to benefit.
You preempted me on that because I was going to pick up on that actually. That it's a good point, and it's reminiscent of the finance space and financial inclusion. It's not going to be brick and mortar. You're not going to go and open bank branches in rural sub-Saharan Africa. It's just actually we're closing bank branches here, right? So I think it's an important, good take on that. Now, we have 4 minutes left. In those 4 minutes, I want to do two things. I want to quickly get your thoughts on health tech regulation. How do you effectively work with governments? What are some tips and tricks of how to get this right, if you have them? And two, if we can manage to squeeze that into the next 4 minutes, can we anticipate what the next big step is going to be, the next big leap? What's on your mind? What are you thinking in terms of what happens next in terms of artificial intelligence in healthcare? So, yes, big topics, but just some brief thoughts from each of you on that.
So regulation, I think, and very quickly, I think the biggest thing with regulation is the regulators need to keep an open mind about AI. A lot of the existing medical device legislation, for example, in numerous places around the world, was not developed with this kind of speed and power and agility in mind. So things like ChatGPT and the large language models are challenging for regulators, but anybody in here who's used that technology can see the power and can see what that could bring to healthcare. So we don't want to put ourselves in a situation where we can't use it. So I think regulators have to work really closely with industry so they know exactly what's going on and what developments are happening in that space. On the second question, I think the next big leap in healthcare AI is going to be making it, sounds like a big phrase, but multimodal. So taking lots of information. So all the electronic health record information that Frank was talking about earlier, along with imaging information, increasingly genomic information. So we've got all these different range of inputs that take it away from simplistic data sets to complex data sets and get more and more down to the right treatment for the individual person.
In terms of regulation, I think what's something that's very important is to come in early and work already with the researchers, with the designers, with the developers, with the practitioners, with industry and government. So what we do is, so we're Secretariat for the All-Party Parliamentary Group on Artificial Intelligence. And we would have three meetings now on healthcare, on telehealth, on prevention, on diagnostics, etc. And I think that it's very important to get everybody around the table and join these conversations before they're voted into policy and regulation. Because at that time, to change something is much harder than to be part of developing it. So honestly, if there's anyone who would be part of that around the table, we have so many meetings with 100 to 120 people around the table to come in and participate in these open meetings and ask questions or present. And I think this is very important because when it's first put in and voted in Parliament, and it comes with the minister and the start implementation, that's where there's a problem. And then in terms of, that's why it's harder to change. The next thing I want to say, in terms of the next thing, I don't want to repeat what you said, but I do think that the issue of variable technology is going to be phenomenal. All, not just the mobile phone, but other types of variable phenomena, and then data messing, that actually the data you get when you take your daily walk, the daily data you get from when you go to the sports center, the data you get when you're sleeping, the data you get when you have your mental health, the eyes, the health of your eyes that looks on your phone, all these things will come together, and this data will be used in many ways, including for health services.
So I think in terms of regulation, it's essential that there are national frameworks that ease the process of assessing the suitability of the use of any AI solution, both at the level of small startups or extending all the way up to the largest companies. And there has to be consistency and a kind of forward-looking approach to adaptive AI solutions as well. And in terms of what the next big thing is going to be, when I spoke last year, generative AI wasn't really the big talking point. This year it is. This year, we had a discussion between ourselves earlier, and that before, just a couple of days ago, I went on to ChatGPT and I asked it to behave like an esophageal cancer surgeon and have a consultation with me. I told it I had a T1 early cancer lesion, and it's essentially put out the framework that I would use in one of my normal consultations, and that's really changed within the last year. I think I would agree with Chris in that that multimodal convergence, a sense of molecular signatures, physiological data, the patient's history, the results from different investigation modalities, whether they're chemical tests or whether they're physical tests or radiological tests, all converging to a point at which they can be put into a standardized algorithm for best practice in decision making that then affects the next step of what a doctor might do or a healthcare worker might do. The automation of that process is just going to become normal, I think, within the next 2 to 3 years even. Very much faster than we expect. Much, much faster than we expect.
I think that sums up the discussion quite nicely, much more faster than we expect. So the conversation next year might be quite different. I remember that chat we had last year, and yes, there was no mention of AI at all. So that's just 12 months. Now, we could go on. There's a lot more to be said, and I hate to cut this panel short or cut this panel off because the conversation was just flowing so organically. I would have loved to just let you guys go on, but time, unfortunately, has never ever stopped for anyone. So we have to obey those laws, and we have to bring it to an end. But I hope that you found that as insightful as I did. Thank you so much for being such an outstanding panel. Please join me in thanking our great speakers. And I have more good news for you. It's time for another break. 30 minutes for tea and coffee. And then I'll see you back here for the final plenary on harnessing the African opportunity.
Yeah, let's get a picture.
Those of you who are attending the roundtable on sustainable infrastructure finance, that's going to be upstairs in the courtroom. Thank you.